the Skype was all set up too, ready to go, right?
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes, like soldiers in their nice clothes, like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this, like sailors in a tempest, like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. That's a new video. We just launched it last month. It's our new opener, and I love it so much every time I see it. And I think a little fun fact is the gentleman who wrote that song lives in the same neighborhood as our videographer who put it together, and he so graciously let us use it just for everything having to do with patients, so living room. So some of you may not know me. My name is Danielle Hicks. I work at the foundation. I oversee patient programs and services. I am Bonnie and Dario's oldest daughter. My sister always wants to make sure that I put the oldest part in first. And I've been working at the foundation for about 11 years. Foundation was started, for some of you who may or may not know, back in 2006, 3 years after Bonnie's original diagnosis. She was diagnosed with stage 3B. She had a tumor in her upper left lobe that had attached to her aorta and subclavian arteries. So she was told there was really nothing that they could do for her, and back in 2003, there really wasn't. I'm happy to say that through a series of very serendipitous events, chemotherapy, radiation up front, lobectomy, some work from a cardiac team on the vessels in her heart. She just on Sunday, St. Patrick's Day, celebrated 15 years of being cancer-free. So she decided that if she came out the other side of this, she was going to do something to give back. Like I said, a lot has changed since 2003, but back then, multidisciplinary care, particularly in the community setting, was not a thing. It didn't happen. It still doesn't happen a lot in a lot of communities. We're going to talk about what that looks like here in Arizona with this great group of docs that are here in the room tonight, and that will be Skyping in very shortly, I'm sure, from the Gateway location where we're also live streaming this meeting. So I want to thank you all for coming. We're really excited about this evening. If I could just remind you to, if you have your cell phones on, if you wouldn't mind putting them on silent, that would be great. And also, I encourage you guys to ask questions throughout this entire event. We do this for you. You have access to these amazing people for the next hour and a half or so. So I encourage you to use that time wisely. There are no stupid questions. A lot of times patients will say, well, I don't want to ask it because I feel like I'm taking away from the rest of the team. You don't know that you're not asking a question that somebody else also wants to know the answer to. So please, I encourage you to ask questions. The Facebook folks and the YouTube live streaming folks, I encourage you guys to do the same thing. We've got some great people from ALCF monitoring that chat. They'll get your questions to me, and I will ask on your behalf. So with that, I'm going to turn this meeting over to Dr. Kuo to start. I decided about 3 or 4 months ago, rather than reading from a piece of paper everyone's bios and who they are and what they do, that it just felt better to have them talk to you a little bit about who they are, what they do, and why lung cancer matters to them. So, Dr. Kuo?
Okay. My name is Dr. Kuo, and I get to work with these wonderful people in this journey of lung cancer. I really want to thank Bonnie and Daryl for giving us the opportunity to really share what we're doing in Arizona and what we're doing for our patients and help lung cancer patients actually throughout the country and throughout the world. Really, my passion about lung cancer is putting together a team to change the way we treat lung cancer and the journey for the patient. Really, the patient journey is what is the most important, and we're not doing a very good job of it today. I think the average time from diagnosis to treatment for lung cancer in the United States can be over 5.5 months. I'm sure many people in the room are listening have lived that journey, where you go from your primary care doctor to a pulmonologist, get a CT scan, go back to your pulmonologist, get a biopsy. It just takes a long time. What we're really trying to do here at Banner MD Anderson, both on the east side, where Dr. Broussard, Dr. New, and Dr. Walker are right now and their team, is to create a better experience for the patients, where you can come in, and we brought many people from the team here that I get the privilege to work with to help in that journey and change that time from diagnosis to treatment to down to 3 weeks, down to 2 weeks, down to a time where you can get together, see everybody at once, get all your tests coordinated. So I'd really like to just take this time to introduce the people on the team here, and then if Dr. Broussard is on the other side, he can introduce the people over on the east side. But right next to me is Dr. Brad Milliman. He grew up in Detroit, but he is our clinical psychologist. Lung cancer is a journey where it's tough, and it's tough for the patients, tough for the family, so Brad can really talk about that, and he's added a lot to our group. In addition, Brad runs a smoking cessation program, so we know that smoking cessation is a huge part of lung cancer. Not everybody with lung cancer smokes, but that's something we can really do. Sitting next to him is Jennifer Wazinski, who really has been a great addition to our team and runs our lung cancer screening program and early detection program. So she is out there trying to spread the word. I think if you had to ask anybody in this room, we had to ask you one thing you could do to really help change the face of lung cancer, I would say that if we can get more people into early detection and find lung cancer early, that's really how we're going to fix lung cancer. I'm really excited about it. So Jennifer helps us along with that. Ravinder Clayton is our lovely radiation oncologist from Canada, who it's always good to have Canadians, who really knows a ton about lung cancer and joined the MD Anderson family probably a year ago, and has been just wonderful to work with, and really an expert, a leading expert in radiation oncology and the use of radiation in treatment. And the honest truth is, the treatment of lung cancer is a team effort. It involves a radiation oncologist, the surgeon, the medical oncologist, the interventional pulmonologist, the health psychologist, the screening coordinator. It's really a team effort. So Ravinder does a great job with that. Dr. Shah joined me about 2 years ago, and it's probably the best thing that's happened to me when I started. And he is an interventional pulmonologist. He actually grew up in India, trained in London, and then has come back here. And he's offered amazing things for people that were never offered here in Arizona before for the treatment of lung cancer using techniques through the bronchoscopy. And he's really helpful both in diagnosis and treatment of lung cancer, really advanced. So if there's any questions in the community about that, Dr. Shah would be an expert. And Ashley Labarre joined our team about a year ago also, and she's a physician assistant. She grew up in Allentown, Pennsylvania. So she actually is now the key cog for our lung cancer screening, our lung cancer multidisciplinary program. Ashley sees the patient first, organizes all the tests that you need, and then after that, it goes to committee where we all meet and talk about what treatments, and then on the same day, you can see medical oncology, radiation oncology, and surgical oncology, and then together figure out what the best plan of treatment is. So that's really what we're trying to represent, and I'd open it up for if there are any questions, but if there are not any questions, then I think maybe somebody can each say something about what they're passionate about and why they are involved in lung cancer and what they think the role and the shape of lung cancer is. Other question? Yeah.
I was told, my thing. The visceral lining, am I saying that correctly?
Visceral lining?
Visceral lining. After my mass was removed from my left lower lobe, the visceral lining, apparently pathologists said that there was some suspicious tissue.
Yeah.
And I understand that there's a 1 layer, 2 layers, and 3 layers.
Yeah.
So Thursday I go for a CT scan. Is that going to reveal if this suspicious tissue is positive, negative, or?
That's a great question. So I think to reiterate that question, I forgot to introduce the people on the other side. There's Dr. John Broussard, who you can't see, but he's a surgeon, who's a thoracic surgeon, has an expertise in lung cancer, and Jason New, who is a world's expert in medical oncology, so he may be able to add to that a little conversation along with Ashley. And then also Gary Walker, who is a colleague of Ravinder Clayton's here, who is a radiation oncologist. Does anybody want to tackle that question, or do you want?
You can go ahead. Ashley, do.
I'll start with the question, and I think that I would love to get Jason's input. The lung is surrounded by a lining called the visceral pleura. And the pleura, the way to think about that lining is if anybody ever makes ribs, if you ever peel the inside lining of the ribs out and that shiny layer, that's what we call pleura. And there's 2 linings. There's one on the inside of the ribs, and there's another lining on the outside of the lungs. And what happens is lung cancer grows, it usually grows inside the lung, but it can start to grow outside the lung. And what they talk about visceral pleural invasion is there's 3 stages that we're starting to look at, and we're just starting to understand it more and more, is it growing outside the orange peel? So what I tell people to think about is think about the lungs as an orange, with the juicy orange being your lungs, and the peel being the visceral pleura. So if the tumor just grows to the inside lining of the lung, but hasn't grown out through the orange peel, that's what we call visceral pleural invasion. And there's 3 different layers depending on how deep it is. And there is new research that is out there, because what we all worry about is we remove the lung, or we treat it with radiation, or we treat it with cryo or some other new technique with interventional pulmonary. Is the lung cancer going to come back, or is it going to spread? So the 2 ways lung cancer often spreads is 1, through the lymph nodes, and that's where Dr. Shah and his team are excellent about diagnosing that, where it goes inside the lung and goes along the pathway to the neighbor's house, to the highway, and then on. Or it can spread directly by growing out into that lining. And that's where I think if Dr. New's on, I'd love for her to get his thoughts on who needs chemotherapy and whether or not. The CT scan you're going to get, it can show that there is spread of the lung, and we just want to monitor that very closely. That's why we're getting the CT scans.
Joe, are we going to get Dr. Neo up on the screen? They're asking questions.
While they're working on that, the other thing I think Dr. Clayton may be able to touch upon is, what the role of radiation is after if the cancer is spread to the rib cage or anything like that causes pain. That's when it's grown out of the orange peel into the surrounding tissues, such as the tissue around the heart, the rib cage. Sometimes if it grows in rib cage, that can cause a lot of pain, and there's a lot of good treatment from radiation for those type of patients.
And one of our colleagues that's not here is a pathologist. So often a pathologist will tell us at the time of surgery what was removed. Was there a possibility that something was left behind? And if we have that information, especially from a radiation standpoint, and as well sometimes from a chemo standpoint, that can then help us guide the next stage of treatment. So sometimes patients do need further treatment, depending on what our pathology colleagues tell us. So the CT scan is one thing, the pathologist assessment is another, and if there's concern that there was some tissue or some amount of cancer left behind, we often do consider adding radiation treatments after surgery, or in some instances, adding chemotherapy after surgery.
Is it dangerous to radiate near the heart?
It really depends on the doses of radiation we use. So every structure in our body can essentially tolerate some amount of radiation. How much each structure can tolerate, we've actually been able to determine based on clinical studies as well as preclinical studies. And so when we talk about radiation close to the heart, things we worry about are, is it close to a big artery? Is it close to the lining of the heart, which can sometimes get inflamed? We know the heart can tolerate some amount of radiation. And so the way we plan our radiation is to try to conform the dose around the heart. So we deliver a very high dose right next to the heart while protecting it to the doses that we know we can take it up to.
So generally the recommendation, I don't know if Jason can hear, and I'm not a medical oncologist, Ashley, feel free to jump in at any time, is that if there is visceral pleural invasion, there is a recommendation today of giving some chemotherapy because there's multiple risk factors we look at for if the cancer is going to come back or spread. While we take out the cancer surgically often, or however we treat it, for early cancer, the success rates and survival is excellent, and patients do very well. We do know that a small percentage of patients can recur or have the cancer come back. The hard part is figuring out which of those patients will come back and what are risk factors. So there's things like lymphovascular invasion, visceral pleural invasion, positive lymph nodes that all increase your risk factors, and depend on that, the oncologist who is a medical oncologist will make a decision whether or not they want to give you something in your bloodstream that can treat it, because that's usually the most effective. Do you have anything to add, Archan?
But the ultimate thing is that you have a meeting with your treating team, your treating physician. Your medical oncologist needs to sit down with you and go over the pathology report, like Dr. Clayton indicated, and the CT scan, and then discuss the benefits and risks of the chemotherapy. What are going to be the additional benefit of you going through chemotherapy is, if you've already had surgery, is the percentage benefit something that you want to take the risk of, compared to the risk of the side effects? Is that something which you want to opt into or opt out of? So it's a team approach, a partnership that you build up with your team, treating physician and his or her other colleagues.
I think a lot of the answers we don't know yet, and that's where the team approach of, after everybody looking at it together, talking about and trying to figure out what the best person, with getting you in that conversation about what the best future treatment or what even the best initial treatment is for you, because as lung cancer treatment evolves, there's more and more ways to treat that lung cancer. Surgery is not the only way. There's radiation, there's cryoablation, there's thermal ablation, there's chemo alone. So there's lots of options, and you just want a team that can sit down with you and talk to you and have you involved in that decision-making process. Yeah.
So besides immunotherapy, which a lot of times is not good for people with mutations like EGFR, it's not, it doesn't really help. And let's say targeted therapy is, you've run the course of targeted therapy, and chemo is like what you end up with. A lot of people in this room have had chemo, and really the quality of life is just really bad, and the side effects are so bad. Is there anything coming down the pipeline or whatever that can replace chemotherapy that's not, that's not as hard to tolerate?
So that's a great question. The answer to that, unfortunately, is not as simple. Number one is the fact that if you're receiving chemotherapy and or immunotherapy, it's likely an advanced stage cancer.
Yes, stage 4.
Right.
Okay.
And what the main thing is, you get systemic therapies because if it has spread to multiple sites, or is it a local recurrence of the disease, or after completing the chemotherapy and immunotherapy, have most sites responded, but there is a new particular site that has now shown up on your recent scan, or one site that did not respond. Mm-hmm. If it is a small area, there are options of local therapy that can be considered, but one of the first things that any person in your treating team is going to recommend is that that particular site gets biopsied again.
Right.
The reason to do that is to see if there's a particular targetable mutation present in that. If not, then there are other options, such as Dr. Kuo has mentioned about cryoablation or microwave thermal ablation techniques, or sometimes a focal radiation therapy can also, depending on where the location is, can also be used.
Well, when you're trying to consider whether it's a systemic thing or if it's even if you're stage 4, if it's just a localized tumor where you can't, let's say it's not targetable, can you use something like circulating tumor cells, blood liquid biopsies or whatever to determine whether you have, whether it is going on systemically and that maybe you should treat it systemically rather than locally, or no?
I know there are for like breast cancer and other cancers, GI cancers, stuff like that. Off the top of my head for lung cancer, I honestly, off the top of my head, don't.
I think
So there are liquid biopsies that are available that can be utilized.
Well, like the circulating tumor cell.
Correct.
Is that a reliable?
Again, the idea is to find an actionable mutation towards which you can treat it.
I know.
Not all the mutations can be found detected with a liquid biopsy, which is a simple blood test.
Right.
And hence, the need often is to go ahead and biopsy again, or look at the next generation sequencing that can be done on the original biopsy that was done, or the tumor that was removed. Obviously, the more the material that is available for the pathologist to run the tests, the better the answer, the more confident they can provide an answer about an actionable mutation, the presence or absence of it.
Yeah, and I think I just want to give a little update on what's happening over in Gateway. They're trying to fix something that's going on with the Skype right now. So, and unfortunately, we're getting out of this medical oncology space, right? So, I want to do like a couple of things because I think they're very important questions that we will get answered. But one of the things I want to say about your liquid biopsy sort of space that you're looking at is there are companies out there that are currently working on trying to detect progression in the blood, right? So I think that's kind of what you're asking. Nothing's been approved. So it's in the fairly early stages, but they are looking at it.
And I think while they work it out with Jason and stuff like that, what you're trying to get at is, and I think what we're getting at is lung cancer is going to change dramatically and advance exponentially, and the treatment's going to change so much in the next 5 to 10 years. We've learned so much from breast. We've learned so much from prostate. We've learned so much from other cancers, and we have organizations like Bonnie Dario that are trying to push research ahead. The national government is pushing research on lung cancer ahead. Every 4 minutes somebody has lung cancer. So those developments of breath tests, blood tests for lung cancer, individualized, personalized treatment is really things that are happening today, and the speed at which they're happening is much faster than ever before. So these are not things we're talking about. Yeah.
But I also like to, I told you I wasn't feeling I really want to talk about interventional pulmonology in this full insight and what a huge role that you all play.
Well, I think we can have Jen start talking a little about screening and then kind of naturally evolve into Dr. Shah talking about a little about interventional pulmonary and diagnostics, and then Ashley talking about coordinating the care. And then from there, Dr. Clayton, Dr. Walker, Gary, Jason Yu, and Dr. Broussard and I are more on the treatment side. So this is, I think, more of the early detection. And then Dr. Millman provides, I think, something that's overlooked a lot is the psychological aspects of lung cancer and how it affects you in your treatment. So, Jennifer, do you want to kick it off?
Absolutely. My name is Jennifer. I'm one of the nurses that runs the nursing lung cancer screening, lung cancer screening. And my team works together to hopefully catch cancer in its earliest stages. I work very closely with all the providers to review all the scans that come through the system, so it's throughout Banner. And I was talking to several of you earlier, we actually review all the ones that are a little concerning and provide follow-up recommendations to your provider who ordered it. And that's kind of my passion with this, is let's catch it early so we're not dealing with all the chemotherapy and things like that. So my team does get to do that, which is exciting. And we've had surgeries on many of them that did not have to have chemotherapy. So.
And there was a national trial that just came out of Europe. The National Lung Cancer Screening Trial was a trial that came out of the United States that started that push to get lung cancer screening in the United States. But the Nelson trial, preliminary data that came out, and it's going to be published soon, shows that in Europe it had even a greater effect of finding lung cancer early. And then there's a Japanese study that instilled lung cancer screening that showed that right now 85% of our lung cancer in the United States are found in stage 3 or above. But in Japan, over 90% are now found after implementation of an organized lung cancer screening program at stage 1. So it can dramatically change the paradigm. We're not where we are today, but through the efforts of Jennifer and her team, we're making dents. And I think that's something that everybody who's listening can make a big effort. I went to a talk recently, and for women, the compliance rate for mammography nationwide is probably in the 75 to 80% of women get their mammographies done, which is great, right? That's what screening is only good if people do it. But for lung cancer right now, of all the eligible people that in the United States are eligible, only 1.3% of the people are actively screened. So there's a great opportunity there for us to educate, encourage people to get screened, and the screening criteria will change. As we go from screening, the next step is what do you do if you found to have a nodule, or how to diagnosis or treatment. I think that's where Dr. Shah and his team come in.
So one of the key things to realize is that screening is done to pick up disease when it's not symptomatic, right? And that's the idea. But everything that a CT scan picks up is not cancer. That's the more important thing to realize. Just because there's a positive scan does not mean it is cancer. And that's what Jennifer was alluding to, that when there is something found that is a little more suspicious, then we have a multidisciplinary approach where we review those scans, those images, and then decide which are the ones that need to have the next test. The test does not necessarily need to be a biopsy. It could be a PET scan, or it can be a short-term repeat CT scan. If it's going to be a biopsy, then we decide and recommend what is the optimal way to biopsy this particular spot. The spots are small, and hence they're often challenging to get to. There is the conventional radiology method, where a needle can be put from the outside to biopsy it. Alternatively now, with advances in bronchoscopy, we can get deep into the lungs and biopsy smaller and smaller tumors or spots successfully and get an answer as to what that spot is about. The advantage of doing it through a bronchoscopy, where we use different techniques like navigational bronchoscopy or ultrasound-assisted bronchoscopy, and the newer thing that is coming out now is a robotic-assisted bronchoscopy. All of these can complement each other. They don't necessarily replace each other, but we have these different tools available with which we can reach deeper into the lung tissue, get a biopsy, and the advantage is at the same time we can perform biopsies of the lymph nodes, which Dr. Kuo had alluded to at the same time. So with one procedure, a patient can have a diagnosis and at least a staging done if they've never had a PET scan before of the spread within the chest.
So I think one of the things that I want to point out when it comes to screening, especially on that very small percentage of people that qualify for screening actually getting screened, and I think in the US it's roughly somewhere between 9 and 10 million people that currently qualify for this potentially life-saving screening, is be our voice for those people, right? You guys, like I said, you walk it, you talk it on a fairly regular basis, and we all know someone who qualifies, right? And the qualifying criteria, it's not like a really long list of something you need to memorize. It's somebody who's 55 or older, who has not quit smoking within the last 15 years, and who smoked at least a pack a day, for 30 or 2 packs for 15. So it sounds very complicated when I say it out loud, but we have this all written down, and we would love your help in getting the word out in that space. So that's all.
Yeah, I think, Dr. Shah, one of the questions that came up on the email session is interventional pulmonary is such a new field. I think a lot of the patients really don't know where, other than diagnosis, what interventional pulmonary can do. And to be honest with you, in Arizona, I think a lot of the physicians are just starting to learn all the capabilities of what interventional pulmonary can do. So
Yes,
touch
so
on that.
It's an exciting time to be in the field of interventional pulmonary medicine because the landscape is changing and expanding very rapidly. In a lot of cases, when we biopsy the nodule and it comes back to be cancer, you had asked about how difficult it is to radiate near the heart. We can place certain fiducial markers, gold-plated or other fiducial markers around the nodule, which helps the radiation oncologist to focus their radiation in that zone and prevent some amount of damage to surrounding structures, including the surrounding lung. That's an adjunct towards radiation therapy. Additionally, what we can do is sometimes these tumors are found in the airway itself, and they end up causing a pneumonia, and hence the patient is more symptomatic in the hospital. We can go in through the bronchoscope and remove at least part of that and even treat that with laser to open up that airway again so that pneumonia improves and they can get back on track for treatment or get definitive therapy. We often compliment my surgical partners when we do the bronchoscopy. We biopsy the airways at different locations near the primary tumor, so it helps them determine at what level they can do a resection of the airway in order to get a clear margin and not have a positive margin that the patient ends up needing chemotherapy subsequently. Recovering from surgery itself is also a factor to be considered, and hence chemotherapy can get delayed if recovery is longer. These are some of the things that interventional pulmonary medicine can do to work in the team. One newer thing that is currently being implemented in Europe and is soon coming to the United States is ablative therapies, thermoablation and cryoablation, going through the bronchoscope, navigating into the nodule, biopsying it, and if the person has advanced emphysema or may not be a candidate who can tolerate surgical resection, then we could go ahead and just ablate the tumor at that time in a controlled manner, and that would prevent certain other recovery period and make them eligible for therapy.
I think one of the things to emphasize about this detection is when we find tumors that are later or have spread or bigger, the treatment options are less successful, but there are less options. When we find tumors that are small, there are 6-7 ways to kill that tumor very effectively. And that, is what I think is the future of focusing on finding things that are a little smaller. Because the problem is lung cancer rarely causes symptoms until it's spread or become very big or grown into something. So you don't need your lungs. I can remove half the lung on a lot of people and the whole lung on one side and they can breathe fine. So there's a lot of excess lung tissue. So by the time we have some of those symptoms, it's oftentimes later in the disease.
Dr. Kuo, there's a question coming in from online, which is relevant to you in particular. After 5.5 years remission from stage 3B adeno with extensive bilateral lymph node involvement, am I a candidate for surgical resection?
So it sounds like the question is a patient who had stage 3 lung cancer, who had multiple lymph nodes involved at the time of, and then had surgery already? Sorry, can you read that?
Yeah. After 5.5-year remission, doesn't sound like they've had surgery.
Okay. So
stage 3B adeno.
So I think this opens a whole continuum on how to treat kind of semi-advanced stage cancer. So when they stage 3B, lung cancer staged 1 to 4. Stage 1 means that it hasn't spread, it's just a small cancer in one area. Stage 2 means it's spread inside the lung in general, but not outside the lung. Stage 3 means it's kind of gone into the middle of the chest, which is considered the highway of the body. And stage 4 means it's spread to the bones and other areas of the body like the brain. So this patient had what we call stage 3 disease, which means the lung cancer has spread outside the lungs into what we call the mediastinum, which is the center of the chest. And what it sounds like from this patient is that they had what we call bulky, or a lot of lymph nodes that are involved. Because when we talk about spread, sometimes it's just going to your neighbor house to borrow some sugar. But sometimes you bring the whole family over, right? And the spread can be very different. When we talk about spread, it's very generalized. Is it a lot of spread or a little spread? If this patient had spread of cancer, I think they probably got treated with chemotherapy with plus or minus radiation for stage 3 disease based on 5.5 years ago, probably got both. And that patient has done super well. 5.5 years breaks the odds, and that patient is doing very well. I think that if it ain't broke, don't fix it. So if there's no signs that the cancer has come back, then I would not offer surgery at this point or anything like that, because we know that sometimes chemotherapy and radiation can kill all the cancer, and this patient, being 5.5 years out, is doing well and beating the odds. But if the cancer does come back, there is consideration of surgery, but I think that you have to weigh the risks and the benefits. So Dr. Clayton can talk about this more, but if they got a lot of radiation. The radiation initially in the first couple times, the tissue is still soft and still can heal, but after a long term, the radiation can cause some pretty severe scarring that makes surgery more dangerous, where other interventions like Dr. Clayton's intervention or more local therapies like Dr. Shah and the interventional radiologists are sometimes better. Everything in life you have to weigh risk versus benefit. So that's where I think that conversation comes in.
So another question online is how do you define a small tumor or a small lesion? What are those parameters?
So let Dr. Clayton answer that.
I mean, I suppose you can look at it from a very structured staging standpoint, but I'll comment from a radiation standpoint, and Dr. Kuo can comment from a surgical standpoint. For myself, a small tumor is something that I think I can treat with radiation alone to an effective dose and kill the tumor without causing too much damage to the surrounding areas. So in terms of actual numbers, we know that radiation alone is very effective for stage 1 lung cancers, as long as the tumors tend to be less than 3 centimeters. I know I can safely treat a lung tumor up to about 5 centimeters while sparing a lot of the lung tissue. Anything beyond that, from a radiation standpoint, becomes a large tumor.
And I would agree. I would say that there's a staging system where you can look up a stage 1 lung cancer is generally under 4 centimeters. We have the best results for tumors that are under 2 to 3 centimeters.
So when you do radiation to a tumor, I had it in my lung, it creates a big mess in there. And my oncology radiologist told me, within 6 months it'll be clear, and meanwhile my medical lung cancer specialist, oncologist, whatever, said it's going to make a mess there for a long time, and I'm not going to know what's going on there. It's going to make you really nervous because I can't see what's going on.
Right.
So as a result, I have like ground glass. I have, what they call a consolidated area. It grows. So sometimes they say, well, we really don't know what's going on in there. So every once in a while, I have a PET scan to see if any of it lights up. Is that the only way you can tell whether something's going on there?
Yeah, and that's a great question. So unfortunately, unlike surgery, where if you have something removed, you do a scan that day and it's gone. With radiation, what happens is all we're doing is we're preventing those cells from dividing, cancer cells specifically. With very high doses of radiation, we're actually able to kill off a lot of cells. But I often tell patients that any cell in our body has a certain life expectancy. So including our skin cells, our lung cells, our cancer cells. If you leave them alone without giving them any growth medium, they're going to die off on their own. And that's really what radiation is doing. It's preventing that cell from dividing and creating progeny. So over time, most cancer cells will die off. In the meantime, what we're also doing is radiating normal lung tissue. And the same thing happens there. Over time, might be months, might be a little bit longer. Yeah. Those cells will actually fade away as well, and they may not be replaced. And what replaces them is scar tissue. And as I'm sure you've seen with scars that we have on our bodies that we can readily see, they tend to actually, in some ways, fade over time, but do you often notice they get a little bit thicker or more fibrotic over the years? And that's very true with radiation. Almost similar to, I don't know if anybody's ever had a keloid scar, or if you've heard of that, that builds over time. Very similar reaction actually happens in a radiated field, even in the lung tissues. So it is very difficult to tell what is scar versus what is radiation. So one of the things we utilize is a PET scan. So after radiation, usually we follow you along with CT scans, but if we see something growing, that's less likely to be scar. If it's stable, it's less likely to be cancer. If we're not sure, we often get a PET scan. If that PET scan is positive, then we often ask somebody like Dr. Shah to see you for a biopsy.
And that's when we decide, based on the PET scan, what site to biopsy. It could wax and wane, like Dr. Clayton pointed out, that it's basically a battle between the cells and your body's own ability to control it after majority of the cells have been killed by the radiation or whatever therapy you received.
I mean, that's the beauty of immunotherapy, and the reason they won the Nobel Prize is that immunotherapy is harvesting your own body's immune system to fight the tumor. So I think the answer to that question after radiation, do we know if the radiation causes scar? Sometimes it's very obvious if the tumor comes back, but I would say majority of the time, radiation has an excellent kill rate and an excellent treatment, so you're probably dealing with scar tissue, and then we're dealing with the question of watching that scar tissue and seeing if that scar tissue changes. But the problem is that scar tissue will change because it's scar tissue as the body remodels. So is that change because of tumor, or is that change because of remodeling? But that's where new techniques and diagnostics, or less invasive diagnostics like Dr. Shah and others, can answer some of those questions. That's where you need to find a team approach, not a doctor that's by himself in a silo, but a doctor like Dr. Clayton who can get the scan and then talk to Dr. Shah and Dr. Me and then Dr. New or Ashley and anybody on the treatment team and be like, hey, what's the next step? What should we do? And then that's where I think the beauty of a team approach is really important. I think we're focusing on, I didn't know if we could have Brad talk about a little bit, or Ashley maybe talk first because she hasn't had much about just how to coordinate the care and how the journey is better for the patient, and then maybe Brad talk a little bit about something that we ignore. We talk a lot about the treatment, but we often ignore, I think, the social anxiety and the mental aspects of cancer and how it's treated. But Ashley, do you want to talk about how care coordination, your view of that, and how it can make a better patient experience?
Yep, so I'll pick up from where Dr. Shah left off. So say he got a biopsy, so most people come to me once they're already biopsy proven new cancer usually. So the first step with a new cancer diagnosis is staging. So that usually is my job as we just started the multidisciplinary clinic. Like Dr. Kuo mentioned earlier, most of the patients come to me. So I'll see them in consult, in clinic, kind of work them up to stage them. So like Dr. Kuo said, I'll get all of the tests done probably within a week and a half, and then we usually have multi-D clinics every Mondays. Is it every week or every 2 weeks now?
Every week now.
Every week. So if they need a PET scan, if they need an EBUS under Dr. Shah, if they need a brain MRI, if I think that they're a surgical candidate, usually send them to the cardiologist for cardiac clearance prior to surgery, get the pulmonary function test, have that all done for them. And then, like I said, they usually meet every week, every Monday, so we actually have tumor board as well. So usually every Thursday, we kind of have a team meeting, you can say, where we all sit down once all of the diagnostic workup is done and discuss what the best option is for them. So we have that opinion there, and then they also meet on Mondays with the radiation with Dr. Clayton, with Dr. Kuo, and then my medical oncologist, Dr. Moore. And they sit down with the patient in kind of a one-stop shop. So they'll come in for one visit and see all three of the providers at the same time and walk out with a treatment plan.
Yeah, I think what Ashley really adds to the team is that she looks at the diagnostic tests as a whole from every specialty. So when you go see a pulmonologist out there in the community, they look at it from a pulmonologist's view. When I go see a surgeon, they order the tests that are necessary for the surgeon. But nobody's looking at what do the tests that everybody needs. And that's where Ashley can really help expedite that and prevent you from bouncing from doctor to doctor to doctor. When they look at what the reason from time to diagnosis to treatment is so long, there's multiple reasons in that pathway. But one of the reasons is that patients are bouncing from doctor to wait for a test, to come back to the doctor, to another doctor, to get more tests, and then get bounced back. I'm sure people have had that journey. You know, what we want to do with Ashley is, you have lung cancer, let's have somebody that can look at all the perspectives or all the tests at once, get you coordinated for those tests, and then get you so the treatment team has all the answers that they need to make the right treatment decision with you. So I think that is what we're really trying to do locally, both on the east and west side. I think we've lost the east side. They're doing their thing. But I don't know if Dr. Milliman wants to talk a little bit about how cancer and that side of the treatment, because that's it. I think the psychological aspect of that treatment is equally as important as the medical treatment. I'm a big believer that people that feel like they can beat the disease or are feeling positive do much better than patients that have been defeated.
Hello, so I'm Dr. Millman. I am a clinical psychologist, as we talked about. I do a lot of things with pretty much all of these providers, taking referrals from them. On the personal and professional side, I've kind of seen the effect that cancer can have on people. It's not just anxiety and depression like most people go to, right? We talk a lot about body image issues with the way your body changes during all of these different types of treatments, different surgeries. We talk a lot about medications. There's a whole lot that I can do. The average patient spends between 5 to 6 minutes in the room with a provider, which is obviously not a lot of time. So, and a majority of the time, the provider is doing the talking, so patients get left with a lot of questions, which is great, why we have these kind of living room seminars. But part of what I can do is help you process what you've heard. Most patients, when they find out they have cancer, don't even hear what the doctor says for the next 15, 20 minutes, and they have so many questions that go unanswered. So we kind of help you manage that, especially if you have a limited social support. I also help people either during, for, or after with smoking cessation. Not every patient who smokes has lung cancer, not everyone who has lung cancer smoked, but it's definitely a big part of what we see. I help people to quit because obviously quitting smoking is good for you, but everybody would say, well, I've tried, but I've tried just the patch, or I've tried Chantix, or I've tried, anything that they see on TV. But why do I keep going back to it? So we like to look at the behaviors that help you see specifically why you're smoking, what was going on that got you to start smoking, and what we can do to help you quit smoking.
Sorry, we're discussing the question we want to ask next about it. Do patients come to you and discuss stigma? Because I know in talking with patients, it's a huge problem. And I think a lot of lung cancer patients don't come out and talk about their disease.
Yeah, definitely. Stigma, I always tell patients that the biggest thing they will ever do in therapy is walk in the door the first time. Because so many people will tell me, well, I don't want to be a burden on my family, or, well, I've done so much already, they've had to take me to this appointment, they take me to multiple chemotherapy appointments or radiation appointments, they have to help me get medications filled out, the financial strain. They say, why add mental health into that? Mental health really isn't that big a deal. We can just put that on the back burner because everybody goes through this, so everybody experiences it. So I think breaking down that stigma is a lot of what we do, which is, again, clinical psychology is really just starting to expand into the oncology world. I wouldn't say that we're at the forefront of it yet, but I think having the opportunity to work at a place like Banner and work on a multidisciplinary team is something that allows us to erase that stigma.
What about mortality? I mean, when I got diagnosed with cancer, the first thing was, I'm going to die. And I mean, and then people say, oh, well, everybody's going to die sometime. I say, yeah, but I got a cancer gun in my head.
Right.
And I think that it's really hard. The hardest thing for me is to discuss with anybody death, because death in our society is, ooh. So, like, I don't know.
Yeah, that's something that I actually really like to talk about because, again, personally and professionally, I've seen this is something that goes untalked about until it's too late. Kind of like hospice care. They'll tell you that 90% of medical expenses are accrued in the last week of life. And that's because people wait too long to take care of things. I like to help people either ease it by talking about it from the spiritual standpoint, biological standpoint, whatever we can do. I myself am certified to help with advanced directives because that's something that I know a lot of people don't necessarily have their affairs in order. And again, unfortunately, we can't save everyone, at least at this point, and it's something that we have to help people prepare for because the worst thing you can do is feel like a burden to somebody else at the end of life when they should be helping you through that transition and helping others.
Well, a way to think about it, actually this was mind-opening for me in my training, is that I always thought that hospice was for the end of life. And if you look at the actual time in hospice is designed for people to be in hospice for up to 6 months, but I think the average stay in hospice is less than a week and a half. So we're getting that patients in hospice too late. In my mind, if you're diagnosed with cancer, we know you're fighting a battle. And that battle may win, or you may win that battle, or the cancer may win that battle. We don't know. In my mind, patients shouldn't. There's another thing called palliative care, which I think he's very involved in. It's a spectrum. While we focus on cure, we need to also focus on patient comfort. Sometimes when we focus on cure, we hurt the patient. I hurt the patient with surgery, for sure. Chemotherapy may hurt their patient, radiation hurts the patient less, but everything has side effects when we hurt the patient. And while we're looking at cure, when we're doing palliative care, we can also look at comfort. Doesn't mean we're giving up. In hospice, that's more of end of life type of discussion. But if I had a dream, I would say that every day somebody got diagnosed with cancer, they would get hooked up with a palliative care doctor, not a hospice doctor, palliative care doctor, that would help them also feel the comfort while they're trying to fight this disease and cure the disease. So I think there's a spectrum, and we ignore that, I think, in the United States until it's often too late, because we're actually, I think, people are uncomfortable talking about death or afraid of their own mortality.
Well, one of the things is that we've become a society of disease management. We talk of a disease, lung cancer or any other cancer or any other, we focus on that. It needs to be more health management. It's ultimately to be more healthy, to manage the process. And in that entire process comes medical management, surgical management as needed, psychological management as needed. We forget the social aspect of life and medicine also completely. Going for treatments, keeping appointments, it becomes a challenge so often to keep that diary, to keep remembering that. And often we end up, as patients develop side effects, which makes us forget some of those appointments too. And then it becomes a cascade of trying to catch up. So it's more than just a disease or disorder management, it needs to be health management. That's my personal opinion. And I may be overstepping or maybe saying contrary to what people could believe.
Well, I say that Jen runs our lung cancer screening. She also essentially is our nurse coordinator for health management, I would say. She is out there beating down doors, trying to get people to talk more about living healthy. And that's living healthy and taking care of the patient is what I think healthcare, when people ask me what's wrong with healthcare, I tell them it's simple. We've forgotten, we've gotten so involved in the treatment, the money, everything involved, and we lost what we all went to healthcare for, which was the patient. We need to get back to that. So I think Jen helps with that.
I was actually going to bring that up when you were talking about stigma. It's really funny because they go to their primary care doctor and they say they've smoked, the 30 years, but we talk to them and it's more like 70. We get them comfortable. I do a lot of health expos. I'm going to the Rangers game on Thursday where we'll just talk to people that are out there having a good time that maybe they know somebody who needs to be screened or they themselves need to be screened, but they tend to open up a little bit more when you go out into the community and really talk to them.
I want to make a comment really quick before we go too far down a different path, because I don't want to have to circle back around, but around palliative care, hospice care, and that conversation, end of life conversations. I don't care how many patients I've talked to, they say as soon as they hear the word palliative care, they just are like, get out of the room, we're not having this conversation. So I think there's a huge opportunity for education in this space, around what's the difference between hospice and palliative care, and this whole supportive health care space, or whatever you guys are talking about. I'm a big fan of it. Somebody asked a question over here earlier about chemotherapy and side effects and sort of, managing all the things that come along with it. And I think if you have a really great, supportive palliative care team on your team during processes like that, those side effects do become more manageable. So it's more of a comment. I don't know.
A simple thing to remember, palliative care is symptom management. Because often we expect that the cough or the pain will disappear with the treatment of the cancer. The cancer treatment, chemotherapy, radiation therapy, are more directed towards killing the cancer cells and hoping that they are stunned enough that they don't grow back. But at the same time, it's not always necessary that they will control the pain or the shortness of breath that came along with that. And that's where palliative care can come in and help manage the symptoms that arise from that. Same thing with surgery. After surgical resection, some patients have longer duration of pain, and they need management of the pain. So palliative care is not about just hospice or end of life. It is an easier way to try and remember it as, okay, I have another specialist who's going to help me manage my other symptoms that are not completely getting controlled with whatever the treatment I'm receiving.
With a different perspective and different focus. I always tell people I've married 14 years, and my wife offers a great perspective that's different from mine. And I think because she offers a different perspective, that's what makes us a strong couple and makes us successful in life. I think my job as a surgeon is to focus on cure. I think Dr. Clayton focuses a lot on cure, some on palliation. Dr. Shah focuses on diagnosis and cure. You need somebody else that's saying, hey, what about the patient and comfort, and how are they doing through the treatment? I think that's where palliative care comes in. I think the stigma that we all talk about is that we need to break people down and encourage them just to have that conversation. Because I'm sure Dr. Millman experiences, once you open that door and people are willing to step through that door, it's a whole new world of treatment and comfort and care that you get, that if you never walk through that door because you're afraid or has a stigma, it really kind of closes that door for you.
I'll tell you, a patient said something very profound to me last week that made me really think about kind of putting this all in perspective. And I said, how are you doing? They'd been diagnosed, they had a head cancer, brain tumor. And the patient said to me, it's really hard. And I said, tell me about that. Hard means a lot of things to a lot of people. And he said, having cancer is like having a full-time job. And he said, I've worked harder to treat my cancer than I worked in the job I was in for 35 years. Between the number of appointments, the number of doctors I have to keep straight, and the number of medical bills, and this one's covered and this one's not, this is kind of where the whole supportive care idea comes in. People look at going to supportive care as a weakness or a loss, but especially in this day and age, there's more that we can do than prescribe pain medication. That's where social workers come in, that's where psychologists come in, that's where this whole team and that whole multidisciplinary approach comes in, is to help ease that burden of the full-time job of having a life-threatening illness.
And you probably often feel like you're alone. I think a lot of people feel alone, but I think that's something that as our program grows at Banner MD Anderson, more support groups, I think patients can help other patients. And there's a lot of value in talking to each other because you guys share similar journeys, individual, but similar journeys.
I have a question.
Yeah.
Well, or just an experience I share. My husband repeatedly says to me, well, you don't have cancer anymore. But my head, in my mind, I'm with this visceral stuff.
Yeah.
Questionable. So I'm thinking, yeah, I probably still do. And we fight. I mean, we sling words back and forth. It's, my marriage is like this now. Yeah. So, I got the cancer going on over here, and I got the marriage going on over here. And family's back south, and I don't know, do I have cancer? I don't know. Or am I a survivor and it's gone? We don't know that yet, right?
Yeah.
Because I haven't had this CT scan.
Well, we know for your case, I know your case a little more in depth than probably other people, but in that case, even if the cancer did not grow outside the orange peel, that orange peel and that part of the orange is out, right? So the cancer is out of your body. Can we look at any cancer patient and say the cancer will never come back, or will you develop another cancer someplace else? We don't. I can't look at anybody, but luckily the odds are in your favor that you're going to do very well and live a very long time. We can always worry. I think I could worry today that I have cancer. I could have cancer. I see young people have cancer all the time. They're younger than me with advanced cancer. I think the key is to get hooked up with somebody that can help you look at the positive, or look at the, not focus on the what ifs, because the what ifs I think are scary, and the what ifs are, in your case, are low likelihood. And I think what you pointed out is cancer not only affects you, but affects your husband, your family. It actually affects a lot of people, that cancer diagnosis. And the one thing we want to do is the cancer diagnosis, we want to bring the family structure closer together, not create rifts in the family structure, because I think that's where really strength comes from, is from your support system.
And Dr. Millman might be able to shed some light on this too, but sometimes you often have to think about the perspective of the person that is talking to you about your cancer. Your husband obviously wants you to not have cancer, and sometimes just recognizing that.
I have been to see him once already. We talked about everything but cancer.
Yeah.
Guess I better make another appointment.
Well, and fear of recurrence is a big thing that I deal with, not just with lung cancer, but with any cancer. Any time that you wake up in the morning and you might have slept on a part of your body funny, but you get a pain, that when you're a cancer patient, that's the first thought that goes through your head is, oh my God, is it back? Or is it a blood clot if you just had surgery? And we have to work through some of those anxieties, and you can't, contrary to what people believe psychologists can do, I can't teach someone to have empathy, right? You can just do your best to explain to your spouse what you're going through, but they're never gonna fully get it, right? Everybody's cancer is completely different. Everybody's cancer journey is very different. The best you can do is try and help to show them this is what I go through on a daily basis.
There's an issue also with those of us who are on targeted therapy, and people see us out and about living what they consider a very normal life, and they figure you're cured, and you tell them, no, I'm going to be in treatment the rest of my life.
Right. It's a chronic illness that we've almost developed in cancer care, which is similar to patients dealing with diabetes, heart disease, but at the same time, there's a bit of a timeline in your head, and that's never going to be taken away from you, regardless of what treatment, how well you respond.
We always worry about progression.
Right.
Now I'm on my first line of treatment. I celebrated 3 years anniversary.
Oh, wow.
Congratulations.
Last week.
Yeah.
So I just want to set the record.
Right.
Well, I can speak from a cancer survivor perspective. I'm over 20 years cancer-free myself. And speaking of your husband, my family's the opposite. I was a 20 when I was diagnosed. And my parents, I don't tell them much anymore if I'm having symptoms, because they still get to the doctor, it doesn't go away. Even after 20 years, it's hard. But hopefully he can understand. But I agree. I think it's more he doesn't want you to have cancer, and so he just wants it out of his head. But for those of us that lived it, it's hard to understand that.
With our team here, we also have an oncology counselor, Esther. Are you hooked up with her? Esther Pineda? Yeah. Okay, so she's really good too for any of you guys. Even if you had any issue, she is a phone call away. She's always willing to talk with you. So even if you, like Dr. Millman said, a provider's with the average is what, 5 to 6 minutes? So there are other resources out there and people to talk to through it. So that's...
I've talked with her twice.
Was it helpful?
Oh, yeah.
Yeah,
We
good.
talked about everything but cancer. Sometimes that's a good thing.
That's sometimes what you need. And I think that I would sense that, this has been brought up a couple times here, but I can look at Ravinder and Dr. Clayton and Dr. Shah and Dr. Millman. I think what we pride ourselves here at MD Anderson is spending more time with the patients. Really, what I'm trying to create is a better system. So I don't just see 1 million patients, but I can spend time with each patient. I love that movie, Jerry Maguire, but it's really about more time with the patients you have. And I think that's where, hopefully, that's what the environment we want to create out there, is that when you're with us, you're part of the team and you have the time. I think I've audited other providers in my group, and they spend on average 30 to 35 minutes in the room with each patient. But some patients need more time, and if you need more time, I think as a patient, if you feel rushed or sometimes you're afraid to bother, the doctor should always give you time. And if that doctor doesn't give you the time, then you have to ask your question, is that doctor the right doctor for me? So I think oftentimes we are afraid to ask that question, which doctor is the right doctor for me? We just go see the doctor that the other doctor recommended, and I think you have to make a personal connection with that doctor to feel comfortable, and I think that's very important. And then I think we're afraid to change doctors sometimes because we don't want to disappoint people. They said he was good or she was good. But in the end, I think I always encourage people to get a second opinion. And if they go with another surgeon, I applaud that because they found somebody that might interact better or they have a better connection with. So there's nothing wrong with that. I'd highly encourage people to get second opinions, but most of all, feel comfortable with your treatment team. If you're getting rushed, if sometimes 5 or 6 minutes is all people need, but if you need more than that, you should ask for that because you deserve that. Do we have any other questions?
Yeah, so before I move on to a completely different topic from some online questions, I just want to make sure that there are no other questions in the room around this topic. So Dr. Clayton, this is for you. I have to go back. Okay. Can radiation be done on stage 4 tumors less than 4 centimeters? And what about proton therapy for that same type of patient?
So that's an excellent question. And in fact, we're starting to find over the years that, maybe just stepping back a little bit, often stage 4 cancer, we think of incurable cancer or cancer where life expectancy is pretty limited. So usually our perspective was to treat stage 4 lung cancer for palliation. So if you're symptomatic from the lung lesion, we treat. We can treat that with radiation, 5 treatments, 10 treatments, and we can help with pain, we can help with bleeding, we can help sometimes with shortness of breath. Over the years, however, what we found is patients with very limited stage 4 cancers, we can actually see some long-term local control rates or systemic control rates, in that some people are 5 years out with stage 4 lung cancer. And those are the patients we want to be as aggressive as possible with. Sometimes that's based on what we see in terms of the pathology report, in terms of our molecular testing to see what types of cancers they have. Those with targetable mutations, EGFR positive patients, we tend to be more aggressive with. And so to answer that question, a 3.5 centimeter solitary lesion in the lung for a stage 4 cancer is something, not only would I say is radiation a possibility, but even sometimes surgery is a possibility for these patients. Another thing that we're starting to see with immunotherapy coming into view of late in the last few years is combining radiation therapy, very high doses of radiation, with immunotherapy. And what we often see is something called an abscopal effect. Essentially what happens is we radiate one area and other spots in the body disappear as well, as long as we combine it with immunotherapy. And this is something we suspect we'll continue to do research on to see whether or not we can really utilize high doses of radiation to treat stage 4 cancers. So I think that's definitely a possibility for this patient.
I want to talk about proton beam therapy.
Oh, sorry, I forgot about the proton beam portion. So I had a feeling proton question probably will come up because it's a very robust topic. something that not everybody knows a lot about because it's a different type of radiation treatment, but strangely enough, very similar to what we do. So most of our external radiation treatments utilize X-rays. Protons essentially utilize a hydrogen molecule to deliver radiation. And the nice thing about protons is it's the most conformal of our external treatments that we do. So if you want to treat this area here, but you want to avoid all of the tissue around, so this black box, which is the body, and this is the tumor, the proton will bypass all of this tissue and only deposit dose right here, which is excellent for treating, for example, kids, because we want to avoid radiating children because they may develop secondary cancers from radiation. It's great for treating a target that's very close to a critical structure, like you mentioned, the heart. What it's not great for is a moving target. So the lung is a moving target. And we've actually had challenges even adopting very conformal treatments in the lung just because of the fact it moves, the tumor moves. So it's almost akin to, if you want to shoot a moving target, you use a shotgun. You don't use something that's very targeted because you may miss. And so protons are still something that we don't readily utilize in lung cancer to this day. But I think that's going to change because the technology is changing in radiation, whereby we are able to target moving targets more readily. Dr. Shah mentioned something about placing little seeds, fiducials, into the lung. And what we can actually do with some machines that we have available now is, as those little markers are moving, our radiation turns on and off as long as they're in the right position. So yes, eventually I think we'll get there, but right now the clinical utility of protons is just not there for lung cancer.
So can you guys talk a little bit about what oligometastatic or oligoprogressive disease is and what role in particular that radiation might play in that? And when patients will ask all the time, well, I've only got like 4 lesions, why can't we just go in and just and zap it up and just keep doing that every time they come back? Then that whole whack-a-mole sort of, concept. Can you explain why? Yeah.
Why we can or we can't?
Well,
so
when you can,
So a little bit of that often depends on the patient's susceptibility to other, I would say, systemic therapies. So is this somebody that can go on to have, further chemotherapies, further immunotherapies, or is this really the end of the line? Is there no other treatments available? And I often say for those patients that can continue to have further treatments, I actually want to be more aggressive because this is somebody, we know radiation is good at controlling disease locally, but it's not going to prevent the spread of cancer elsewhere in the body. That really has to stem from utilization of chemotherapies, immunotherapies, if we know they're stage 4 cancer. Often where we come into play is, and Dr. Kuo alluded to this earlier on, is say you're treating, patient has 4 different lung lesions or even lesions in the bone, but 4, 5 lesions, not widespread disease. We treat it with chemotherapy or immunotherapy, it responds, maybe 2 or 3 respond, 1 doesn't. Maybe that spot just has a different biology, and maybe that's the spot we need to target with radiation, or possibly even remove it with surgery and then look at, what does that show us? What's the pathology of this? Is this different from what we've been treating? So that's often one of the things I often look at is, is there other treatment options and not just the radiation or the local therapy?
I think it's also good to break it down into 2 types of treatment. If you have cancer that's in multiple places, that means we knew the cancer probably spread somewhere. So you need something we call systemic. That's chemotherapy, immunotherapy, something in the bloodstream, something that can fight multiple areas at the time. What Dr. Clayton and what I offer is what we call local therapy, and what Dr. Shah offers is local therapy, meaning you treat one area that's only in one place. So I think as systemic therapy is getting much better, we're able to do much more treatment and much more individualized treatment. And it's really the change in chemotherapy and that field of targeted chemotherapy and individualized tumor that's going to blossom. And the reason it's going to blossom, we've learned a lot of lessons from breast cancer. Right now, we treat when, let's say, you treat a cancer and then a new cancer comes back, this is where Dr. Shah is going to come in and his new techniques to have biopsy things, because we know that cancer that comes back is not always the same cancer as the cancer was there the first time. It may have mutated, and that's why that mutation was able to survive the treatments that killed 98% of its friends, right? So some additional biopsies, targeted, treating each tumor individually, I think is really where the next few years the treatment will really evolve to. Yes.
What about pain management? Is it? I did those 2 chemo treatments.
Yeah.
And because I was so sick, that's why I didn't do the other 2.
Yeah.
And, you know, ibuprofen just didn't help me. Tramadol didn't help me.
Yeah.
Is there somewhere on the horizon pain management program, or what are we managing? How are we managing pain?
Yeah, so that's a great question. I think we can all probably address this, but the opioid epidemic in the United States has been a huge problem. A lot of people get their first exposure to opioids from physicians, mostly, and then become addicted. I would say if you ask me what the greatest advancement in surgery in the last 5 years or 10 years is pain management. It's not perfect, but we've actually, what keeps patients be able to leave the hospital on day 1 or day 2 versus day 7 or day 8, 5, 10 years ago is pain control. And we've learned that before we just used to give people opioids, and attack one pain sensor. But actually what we've learned is that you have multiple different pain sensors in different areas to attack that pain with different modalities of drugs, from local injections to, you know, nerve pain drugs to actual pain drugs using anti-inflammatory drugs. So now, actually, I would say that if you look at our surgery, we do probably 96% of our surgery through small incisions. I think that's important to we can touch on that topic if we have time later, the evolution of surgery. But most of our patients go home without any narcotics. And I think that's helpful. But do people have pain? Yes, they have pain. And that's where I think palliative care, comfort care, pain management needs to get involved. And I think that, I sense that when you talk about you did 2 sets of chemo, then you didn't do the rest, that was a failure. That's not a failure. I would look at that as you made a decision on a risk-benefit time. The risk of recurrence for you is very low, and the benefit of chemo probably added a little bit, but too bad Jason New is not here, but they talk about a 4% increase in survival. I don't know what they quoted you, but something that's small for the additional chemo, and if it's making your life miserable, then in my mind it's not worth that 4%, you know, increase that you get. Oftentimes, I think a good question to ask your oncologist, and Jason would be great, and Ashley is very helpful in this, is, you know, Ashley's more on the front end, but Jason on the back end, unfortunately he's not here, is, you know, how much is this chemotherapy going to really improve my survival? We don't often ask that question, but the answer to those questions, sometimes those numbers are very low. And I think if you're 20, 4% makes a big deal. If you have, you know, if you're 80, 4% may make less of a deal. And I think that's where individually those questions, I think you should always ask, what does the data show that this treatment will do for my survival? And then you make a decision on the risk versus the benefits. But I think you made a great choice. You did 2 cycles, made you miserable, and you decided not to continue. I think that I would support that decision 100 times out of 100, because I think you tried it, it wasn't the right thing for you, and then we make another decision, right?
The new last tip was the worst.
Yeah.
Often people say that, yeah.
But all of us are built differently. And it's not necessarily that all of us will have the same side effect profile, same adverse event profile, or the same response. And so what may be necessarily correct for me may not be perfect for Ashley, and may be even better for somebody else, right? So it's like Dr. Kuo pointed out, that you went ahead and tried it and realized it is not for you, and hence you decided to not pursue it further.
I think that's such a solid point, because it's definitely not a one-size-fits-all type of deal, right? But it points back to why it's so important to be having those conversations with your physicians, right? To be digging deeper into the odds and what this really looks like, and kind of, that scale, and for them to understand your goals of care, right? That's a huge part of this this conversation. Yeah. Does anybody else have any comments? I will give everybody a little fill-in on what happened with our friends over at Gateway. It was I apologize profusely. They tested it a couple times this week, out here, out there. Everything was working. From what the best I can understand is it was on their end. Something went awry, but they continued to watch this show through the YouTube, and then decided to have their own little support party over there. So everything went okay on that end. But I do apologize that we didn't have particular medical oncology here, because I think there were a lot of questions that pointed back to that. Does anybody have anything in closing that they want to say? One of the things I also caught wind of over there is, and I'm curious how you guys feel about it, just talk about shared decision making and opening, the doors for these types of conversations, was they asked the patient, the docs on the panel in the other room or the other hospital, asked the patients what they could be doing better. Like, they wanted to know from the patients, what am I not doing that you need me to do? And I think that's an interesting question that I think people in the room.
That's a great question.
Yeah.
That's a great, because it helps us understand what you need other than what we are providing.
Yeah.
And unless we understand that, how are we supposed to meet that need?
Absolutely.
Does anybody, okay, thanks, Marcia.
My question concerns progression, because I've been on the same medication for 3 years with no change. My cancer is stable. I always wonder and worry about what progression would look like for me and how it would be determined. I have a CAT scan every 4 months, brain MRI maybe every year and a half. That's about it.
So progression means so many different things. It's hard to, of course, comment on that as specific to your case. But your question about what progression could mean, I mean, we've all been there. We've seen patients on the other end where it does progress. And, it can be as simple as an abnormality seen on the CT that's small, easy to target, to progression whereby patients can develop disease elsewhere in sites they never had before. So, for example, the brain. Can that happen? It certainly can. The longer you are out and longer that you've been on stable medications, the better the outcomes. The reason we do a lot of these tests is, of course, to pick up progression, but pick up progression at a point where we can still treat you and hopefully get you into remission yet again. So if we pick up disease early on, perhaps we can treat that with a different type of drug. So that's always the problem with cancer. It is a mutation to begin with, and it can continue to mutate and change. And it may respond to a drug for many years, and sometimes it can change and not respond to that drug. And that's where we want to pick up any sort of changes. And so it's hard for me to answer exactly what that may look like for you. It may not ever happen for you. The systemic therapy may have already targeted every single cancer cell in your body. We just don't know. Are there treatments if there is progression? Yes, there are many treatments available. So it depends again on location, but even in the brain, I've treated patients with up to 15 brain lesions to try to get all under control. Is
that stereotactic or whole radiation?
Stereotactic radiation. So trying to target each lesion with just a very conformal dose of radiation. I'm sure Dr. New's not here, but Ashley can comment on often seeing patients having progression and then maybe changing systemic therapies, moving on to an immunotherapy, a systemic therapy, or a targeted therapy that again can try to put you back into remission.
And there's national cancer guidelines that we follow, which kind of lays it out as well. They give us first line, second line, third line. There's always more
Yeah.
And I think something to keep in your mind is that we don't have the answers to all these questions. And like, for instance, do you still need to be on that medicine that you're on every year that you've had no recurrence? Could you stop it? We don't know these answers, and I think that breeds uncertainty and kind of, because we just want to know, like, hey, this is the right choice, this is what we're going to do. And that's why I emphasize that you and your care team need to come up with what's the right choice for you. The right choice for you is not necessarily the right choice for anybody else, so you really need to come up with that. And I think you had a question.
Yeah. What about clinical trials?
So that's a
If you don't want to go on chemo, let's say you're coming off targeted therapy, you don't want to go on chemo because,
Yeah.
And everything you hear about, it's like the side effects are just too horrendous.
Dr. Kuo, will we just repeat the question before you
the
answer?
question was, when should somebody look at clinical trials or stuff like that? I don't know if Dr. Shah or anybody wants to answer this.
The answer to that is actually very easy. At the time of diagnosis, and we actually do that in the tumor boards, is every patient should be screened for eligibility in the various clinical trials that happen. And at that point, whenever the consultation happens with the specialist who's going to manage that, partner with you for that, they should be bringing up that clinical trial, and then you can make a decision whether you want to opt into the clinical trial or opt out of the clinical trial. As newer and newer drugs are coming out and clinical research is happening at a pace which it was never happening with lung cancer, it's fortunate that there are more trials available, and you may find that at your next 6-month follow-up, there may be a new trial that you're eligible for. So if your provider or your team is not bringing that up, it does not hurt in you asking that question, hey, is there a new trial, or is there something that I can at least find out more about and have a dialogue and discussion about?
I think most clinical trials today are geared toward advanced stage cancer, unfortunately. But there are more and more clinical trials coming out for early stage cancers. I think as we evolve, we're trying to find out if it works or not. And that's where you need to make a personal decision if you want to be on a trial. A trial means something that is not completely proven, has some preliminary data that is very promising and could be better than what's out there, but it could be worse. And that's where I think a discussion with the oncologist, Dr. New actually unfortunately isn't here, but he runs most of the lung cancer clinical trials, and he has a lot of clinical trials that's a very fair question. Is there a clinical trial I would belong on? And what is the benefit of that, theoretical benefit of that clinical trial? Then you have to make a decision on whether or not you want to go with the standard of care or try something a little more experimental that may be better. So I think that's a personal decision. And I think that being part of a multidisciplinary team where they can discuss the different clinical trials, because there's trials in radiation, there'll be trials in surgery, there'll be trials in chemotherapy. That's where we can figure out, tailor what, and offer you with what's best in your mind, and then it's a joint decision. So I encourage people to think about clinical trials, because that's how we advance medicine, is through clinical trials. And we need patients that are willing to take risks to try to advance, but we don't know for sure that all the clinical trials will have positive results. I think, I thought the question that we got away from a little bit, that you guys all have had journeys. Everybody in this room, I recognize, has had a journey through lung cancer. Is there things about your journey that could have been better? We'd love to listen to what we could do better. I think that's a fantastic question that came out of there.
I think one thing is the radiologist who reads your scans.
Yeah.
I'm a snowbird, so I get treated mostly in Seattle, but I have got treated here as well. And I find that I've been to Smile, I've been to Valley, whatever I've been to Honor Hospital for there, and I find that they just miss things like crazy. I had a fractured, I was in such pain, I thought it was my lung, progression, and I had a fractured rib. They missed it in the bone scan at one place, they missed it in my CAT scan. So it's like, And also, even in Seattle where I trust them, it's a very good radiology place, and it's the same radiologist who's been reading my scans. The last time I went, he said there was something near my heart, that's why I asked you about the heart thing, that's looking a little more suspicious, more like a nodule, but he doesn't know, so they're going to do a PET scan next time I go back there in May. But he never mentioned that I had something in my last scan. in that area, because he said he was comparing the two. So it's like, you know.
I think that your question's great. I think quality of care, this kind of transition in my mind of quality of care. How do you know that the people up here are good doctors? You don't, right? You don't know that if I'm a good surgeon. You don't know if I'm good at what I do. I think as the United States evolves, there will be public recording of quality data. And our goal at MD Anderson is to raise the bar, so you set a high standard and people know that bar. But I think radiologists, we have a thoracic radiologist as Dr. Morris and that we work with, and Dr. Hogland out here that we work with, that specialize, and we trust them. But people will miss. But as technology evolves, there's computer-assisted diagnostic tools now that can help the radiologist. Not very widespread, but being developed, where they can follow algorithms and the computers can help prevent missing stuff. Because if you're looking at 1,000 scans a day, you're gonna
that's what I'm saying.
You're gonna miss
Yeah,
some
yeah,
things.
yeah.
So I think technology will augment what we do, and I think that we need to, as the United States moves, the quality decisions need to be more educated, right? When you go buy something from Home Depot, or if you buy, let's say you buy a hamburger, you either go to McDonald's, Wendy's, or you can go to Morton's. There's quality differences, and each of those qualities comes with a certain price difference that you can. And as we evolve in the United States, we need to stand up for quality. We haven't done that in the United States. As physicians, I would say that we haven't done a good job of enforcing quality. Are we able to get rid of the super bad guys? Yeah, the super guys that stink are out, but then there's a whole spectrum of quality that the patients have a hard time discerning.
But when your progression is based on these,
Yeah.
3-month scans, this is what this is pretty much what they're going from.
For sure.
You asked what can you do better, and I'm not saying
That-
any of you, whatever, but
No.
have radiologists that really read the stuff, that don't have to do 5 million and have like 2 seconds to read your thing, or that are so focused that you have lung cancer that you can't see that you have a fractured rib or something. It's just, that's really important.
No, I think I agree with you. That's why specialty care of specialists that focus in certain areas is completely the future. It's impossible to know a little bit about everything. That's why I think specialists
Right, and if you look at
thoracic
it,
radiology will help.
That's how specialty care has come into evolution. In the olden days, or years and decades ago, a physician coming out of training would do everything. A general surgeon would operate on everything. But now we are seeing separation. Cardiothoracic surgeons would operate on the heart, do bypass surgeries and lung surgeries. But now, just here in the modern times, we are seeing a thoracic surgeon separate out from a cardiac surgeon because there's specialty, developing. And to add to that, in today's era, there's artificial intelligence, which is computer-generated algorithms which these scans should run through and help assist the radiologist, or assist even the ER physician, or assist a interventional pulmonologist or other similar specialties.
You don't go and look at you wouldn't go and look at a scan. You look at the radiologist report, right?
Well,
we
that's
all
not
look at
true
the
in our
scans.
practice.
We all look at the scans
We
ourselves.
look at the scans ourselves.
But we're not radiologists at the same time.
We are not board certified radiologists, but we still look at them. But that's just the way we practice, that's the way we train, and that's the way we learned from our patients that, hey, there's more value in looking. In fact, when we sit down with our patients, we have a TV screen where we are displaying everything to them, and they're looking at their scan at the same time as we are looking at them, and we are pointing out what we see, what we don't, and what we're worried about, and what is questionable, right? But to add to that, just, a lot of the industry is gearing towards using artificial intelligence to help pick up or identify certain spots, which, the human eye has its own limitations. Yeah. A human eye at 9 a.m. in the morning, fresh, is different from a human eye at 4 in the evening, in the afternoon.
I had mine in the morning, though.
And I think that.
But was it red in the morning? Was it red in the morning?
That's true. I don't know.
And I think that one thing that you can, I think what you targeted is a problem. 100%, something that we can do better in healthcare. Guaranteed. I think one thing that we can help on a personal level today is if you get the scan, have your old scans, or bring your old scans. The problem with is that we have a lot of radiology, different technologies and systems that don't talk to each other. So if you have it at Valley, and then you have it at Simon Med, and then you have it at Banner, it's hard to compare the old scans. So to be proactive, I think one thing I would suggest for everybody is every time you get a scan, ask them for a CD. They can burn a CD, and then when you go to the next place, if you go to a different place, see like, this is my old CD, can you make sure you compare to the old one? Because when they compare, then they take, it's not just one spot in time. Now it becomes a continuum that they can see progression and stuff like that, especially if you're traveling between Seattle and here, there's a gap that they don't see that progression. So I always tell patients, you're the best advocate for yourself. So, that's something that doesn't solve that problem, but can make it a little better because, if they see somebody else read it, they may have the same person read it or something like that can be helpful too.
Along these same lines, is a scanner a scanner a scanner? Does it matter if you're getting it just scan in Seattle and then you're over here and then you're over there? I mean, are they all calibrated?
The short answer is no, but
would be
Ravinder
standard,
probably.
But the algorithms that the scans are done in could differ.
Which could affect measurements.
Sensitivity, and there's different 64, 128. Dr. Clayton's probably the most, she understands this stuff the most.
I would say for lung, our primary modality for imaging is CTs. And by far, CTs have been around for a long period of time. And for most diagnostic quality CTs, they're good. I would say there's not that much of a difference between one in the community versus one you're going to get at an academic facility. There probably are some minute differences, but not significant enough that they would miss something obvious. Where things can be a little bit different, it doesn't necessarily apply with lung so much, is MRIs are definitely very different, can be different qualities depending on what you're looking for. Not so much with the brain, but certain other areas of the body, for example, prostate, we only have certain MRIs that we utilize to examine the prostate, and not every facility has that. PET scans are something we use fairly frequently with lung imaging because we want to see what sort of functional activity there might be of a lesion. And I would say by and large, they're also utilizing a CT scanner, and all they're doing is adding a radioactive dye. So really, you're not going to get that much of a difference necessarily between a PET scan in one place versus a PET scan in another place. I think it's very important, Dr. Kuo pointed this out, to have continuity, probably the most important thing. Having the same scan read at the same facility at one point in time and then another can probably be more helpful than having a very high quality CT or high quality PET scan being read at a facility that doesn't have any of your prior imaging or even has that comparison. Because then you are truly comparing apples to apples versus an apple to an orange.
This was the same. It was the same radiologist.
Oh, okay.
I think you can never, we all make mistakes. I've made mistakes. And human error is something that happens. I think what's going to change is that technology will help minimize human error as much as possible. We never want to make a mistake. You feel horrible when a mistake happens or a bad outcome happens. But I think in surgery especially, if we talk about advancements, I think robotics today don't add a lot, but the future of robotics is robot can, or artificial intelligence can look at 3,000 lung operations, 5,000 lung operations, and figure out the intricacies, right? I have a friend who's a pilot. He tells me he doesn't even fly the plane anymore. He sits there, pushes the button, the plane takes off. He pushes the button, it autopilots, and then he pushes the button, and he lands it. He doesn't even have to land it. As that computer technology gets better and better, this is a bad time because there's that whole, airplane issue of crashing. Yeah. But the role of the surgeon, the role of the physician will be to augment what technology helps us in the future. And I think we're also at the cusp of a huge technology revolution in all the treatments that we have.
The other thing that
The other thing that I, as a patient, would like, my providers to be more open-minded about complementary medicine.
Right.
Sure.
I had a doctor, I won't tell you who she is, at Mayo, who totally flipped out on me and just got so nasty and unbelievable because I told her I was going to an oncology naturopath that the integrative doctor at Mayo had suggested because they have a lot of faith in him and whatever. And so, and even my doctor in Seattle, he's kind of, but
I know that I know a lot of patients, lung cancer patients who do complementary medicine. They don't even want to tell their oncologist what they're doing because they know that they're going to get, yeah, you can do that, you know, whatever. And because you guys are really, you know, whatever, whoever's out there. There's some close-minded people there, and there's a lot of stuff going on, especially with repurposed medicine, you know, off-label drugs that are showing promise. Even I know Dr. Haymack and Dr. Swisher, because I speak to them through EGFR resistors. We have conference calls sometimes, and he's looking into something as well with that. There's no money in it because pharmaceutical companies aren't going to make any money, but there is some promise with these things, and so some practitioners are, you know, are prescribing these things for patients, and their patients are afraid to tell their oncologists that they're on it because they're going to get, you know.
Well,
so.
Takes you to the same concept that we want to say that it's a multidisciplinary, multi-pronged approach to the management of the cancer. And like Dr. Kuo pointed out, that as a patient, you need to be your biggest advocate. And what helps you? Sometimes the pain medications that we may prescribe or the therapies we may prescribe, this is just an example because pain was raised as a question, may not be adequate to control, and an alternative form of therapy may help. We don't necessarily know the answers to every question. We are in this learning phase as much as you are.
But that
to
is
help you manage things the best way they are needed for you.
People are afraid of things they don't understand. So the honest truth is I don't understand naturopathic medicine. You know, I'm Chinese. My grandma used to go to Chinatown and this place that smelled very fragrant, depending on how you thought about it, and had these roots from all these different things, and they would mix them together. And that's how she would treat her diabetes and stuff. And sometimes it worked, sometimes it didn't. I think, to be honest with you, all the Western medicine is from those roots, just refined in a different way. I think maybe what you're suggesting is that there should be some naturopathic on our therapies as we incorporate more medicine, as those become more mainstream. I think they will be.
Because there are certain supplements and things that block specific pathways that cancer will take when they're trying to bypass, you know, what you're already targeting. So that, and they are useful, but it's just a matter of, you know.
I would encourage patients to be open about their physicians about what they're taking. If you're afraid of telling your physician what to take, then that's probably not the right physician to treat you. And I would say that because sometimes when you take things, it interacts differently with other medicine that they may be trying to give you, and when that medicine's not working, they're like, I don't know why it's not working. And you may not know that. And so I think if you need to find physicians that listen and are open-minded. But I agree, as a community, we could be more open-minded, 100%.
And I will even say, even from a radiation standpoint, there can be a lot of interactions with supplements. So I truly try to encourage my patients to tell me exactly what they're on. And I don't necessarily discourage anybody from stopping treatment unless I know there's an actual interaction, at least during therapy. After the facts, I often leave it an open book. You know, I'll say this as Dr. Kuo has, I don't know enough about naturopathic medicine to really guide your treatment or to even give you guidance as to whether or not this is right or wrong. The only thing we can often do is we usually have some idea whether or not it would interact with the treatment we're offering. And at least that should be something that hopefully you have an open conversation with your oncologist about.
And I think there's a fear that there's a lot of people that, for instance, go across the border, get some treatments, it's usually steroids, and it gets better. Unfortunately, having cancer is a vulnerable state, and when you're vulnerable, there are people that want to take advantage of you. So I think as a practitioner, I'm always worried that you're going to get taken advantage of. And that's not the right thing. I agree with there's a lot of good things that helping people. So
I just wanted to pay a compliment to Josh, who is not here, the pharmacist at Banner. Absolutely wonderful. You know, when I was getting my first chemo, he came in and said, bring all your medicines with you. And I was on a lot of supplements, vitamins, and all this stuff. And he went through every one of them, and he enlightened me because he read the labels of what the ingredients were and explained to me that the ingredients in these things can really screw you up if, with the chemotherapy you're taking or whatever medications you're taking. So, one for Josh.
Yeah.
Just wanted to say that.
But that's great. I think what you're pointing out is our team, every team needs somebody that can spend that time and help you go through your medicines, and you should be honest with your medicines because there are interactions that we don't know about. And maybe in the future we'll have a pharmacist on a panel that can speak to some of those things because they really understand the drugs much better than we do.
So it looks like I was going to say we have time for one more question, but we are almost on the nose. Thank you all so much for this opportunity tonight to come and talk to everybody. I think it was great. I again apologize about what happened.
I think in full defense, she's very apologetic for it, but this is the first time that they've tried to do a bilocation. I was the one that suggested that, so I should take majority of the credit for
I wasn't going to point a finger, I promise.
Because Phoenix is a very spread out area, and you can't touch base between the east and west as easy because it's a long drive. But I think just like this technology, I bet you if we do this again, will work perfect.
They tested it this week.
And
It
everything
works.
will improve, and these are little kinks, just like as we progress in medicine. So I think I really need to thank Bonnie Adaro for giving us the opportunity to reach out to the people in the room, the people in the East Valley, the people on the internet to really ask questions. I think we focused a lot on the patient side today, and I think that's important. The actual treatment side questions we can always answer too. So, Bonnie, I really thank Bonnie Adaro and the foundation for their continued support. And I really thank them for being a leader in lung cancer. I went to a breast cancer walk with my wife for a friend of ours, and there were thousands and thousands of people, thousands of awareness. And I know at dinner tables people talk about breast cancer very freely, but I think what Bonnie Adaro is trying to do is try to change that stigma, change that perception. Over the dinner room table, you can have it talk about lung cancer. Should you get screened? Should you not get screened? I encourage that everybody listening, everybody in the room, you are the future of helping us cure lung cancer and beat lung cancer, because it's the conversations about lung cancer that create awareness that allow Bonnie Adaro and everybody else to do what they do to try to beat this disease. So really, Bonnie Adaro giving us the opportunity to do this was very special.
Thank you. And thank you all of you for turning up.
I just had to do a couple of little housekeeping things outside of the thank yous to patients and our great panel here, everybody watching online, the film crew who came out and they've been out here all day setting up and taping things to the floor, to the country club, Sun City Country Club, for putting this together, letting us use this room, getting the food all set up. Same thing out in Gateway. I think they had barbecue over there tonight, so a huge thank you to them too. Tomorrow we have another living room, so anybody who might want to, it's not here, it's back in California, but anybody who might want to sign in and watch, we have Dr. David Carbone coming from OSU to expand on a lot of things that we talked about here today, particularly sort of chronically managing disease and how using, disciplines, across this type of team and even, a more expanded team, how we might be able to manage, or what does managing lung cancer look like today. So that's tomorrow at 5:30 PST. You can sign in online to watch that, or just watch it on Facebook Live. Then on March 26th, which I think is next Tuesday or something like that, we'll have a living room in Dallas. So we'll be in Dallas, Texas. Anybody who's watching that wants to come out and see us, if you're in the Dallas area, please do so. That will be Dr. Mason, Dr. Kirkpatrick, and Dr. Gerber. So we've got UT Southwestern, Baylor, and Dallas Presby representing at that. Then March 30th, Sacramento. Anybody who is in Sacramento and wants to come out for our 5K, please do. Dallas 5K and Memphis 5K are both April 13th. So those are my upcoming events. Any opportunity we can get to let you guys know where we are and what we're doing to spread awareness and raise money for this, we do. So thank you, thank you, thank you. It was a wonderful evening. If you did not eat, please grab some food. And that's it. Have a great night, everybody.
Thank you.
Yeah.
This is so hot. I know. This is so warm.
Thank you.
Thank you. Yes, absolutely.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. Yeah, we can both be heroes, like soldiers in their nice clothes. Like soldiers in their nice clothes, together. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this, like sailors in a tempest. Like sailors in a tempest, together. And it could be just you and me. We'll be family. Just wait and see. So I'll be brave if you're brave. I'll be brave, but only if you're